Contraindications of laparoscopic surgery is very important to remember. So, contraindication of laparoscopic surgery, one of the most important contraindication of laparoscopic surgery is severe COPD and cardiac disease. Any patient who has severe chronic obstructive pulmonary disease and cardiac disease, you are not allowed to do laparoscopy. You will be in trouble. Any patient who has severe COPD and cardiac disease, you should not perform laparoscopy. Question is why? What is wrong in laparoscopy to do with? Problem is not laparoscopy, problem is pneumoperitoneum. And these are the 4 major risks of pneumoperitoneum. These are 4 major risks of pneumoperitoneum. Due to that, we should avoid doing laparoscopy in a patient who has severe COPD and cardiac disease. First is decreased venous return and cardiac output. In university, they did one study. In the large animal, they put the different gases in the pneumoperitoneum in Johns Hopkins, and they watch that what happens post pneumoperitoneum. In the first group of animal, they use 6 millimeter of mercury pressure by a plastic varus needle in a 70 kg of chimpanzee, and they observe it for 24 hours, that what is happening to animal, and there was no change. Animal was okay, eating, drinking, sleeping, all the parameters, all the vitals were fine. Because our vena cava pressure is 6, and if you put only 6 millimeter of mercury pressure, vena cava cannot be compressed, diaphragm cannot be compressed. So, any animal of the large animal of human size can tolerate it. Second group of the animal, they use 12 millimeter of mercury pressure, and again for 24 hours. In 12 millimeter of mercury pressure, there was 20% reduction in the cardiac output CO, 20% reduction, because vena cava pressure is 6 and your pressure is 12. So, CO2 is not only lifting the abdominal wall, it is compressing the vena cava also. So, venous return decreases. Now, third group of the animal, but still the animal was, vitals were normal, pulse, BP, respiration normal, but animal was not willing to eat, not willing to drink, lying very sick, but survived, 24 hours survived. Third group of animal, they use 18 millimeter of mercury, and for again 24 hours, and within 6 hours it was unconscious, it become unconscious. And in the fourth group of animal, they use 24. So, 6 millimeter was increased, and here within 3 hours there was death. So, the inference of this study is that ideal pressure should be 12 or 15. If just you go from 12 to 18, pressure is increased only 1.5 times, but venous return decrease approximately 40%. Here 40% reduction was there in the venous return. So, if patient is already cardiac compromise, hidden ischemia, ASD, VSD, previous any cardiac bypass surgery or multiple stent was applied, then this 40% reduction in the cardiac output will precipitate the ischemia, and he can get intraoperative heart attack or maybe the infarction or death. So, that is why any patient who come with a laparoscopy with the previous cardiac history, you should send for stress echo or dobutamine echo. Normal echo does not have any value. A stress echo, if he can run, If he is obese or physically not possible, then dobutamine echo has to be done. And if ejection fraction is less than 40% and any positive ischemia, then laparoscopy is not performed. Open, no problem, because if it is surgery is must, open can be performed, because in open intraoperative intra-abdominal pressure is not increased. But laparoscopy, why it is problem? Because venous return will decrease. So, that is why any patient who has COPD and cardiac disease and decreased venous return, you should not do laparoscopy. Another problem is that it creates decrease in tidal volume. In the same study, they observed that what is the effect of tidal volume. At 6 millimeter of mercury pressure, there is no change in tidal volume, no change in TV, tidal volume was same. Normal tidal volume is how much? 500 ml. With each breathing, we inhale 500 ml in and we put 500 ml out. So, in normal there was no problem, but once 12 millimeter of mercury pressure was done, there was 50 ml reduction in the tidal volume. So, it was only 450. When 18 millimeter of mercury pressure was done, then there was 150 ml reduction in the tidal volume. And when there was 24, then dramatically 300 ml reduction in the tidal volume. That is why patient died, because if 500 is required, only 300 ml was given. And remember, whenever lung is in problem, heart is compensating. So, already tidal volume is also decreasing and venous return is also decreasing. So, lung cannot compensate heart, heart cannot compensate lung. Whenever we have a heart problem and we need more, then what we do? We have a tachypnea, breathlessness. Why? Because more oxygen at least will go, so that heart is not working, then lung will compensate it. And if lung is not working, heart is taking tachycardia, so that will compensate, but here both the side is a problem. Heart is also decreasing the venous return and the lung is also decreasing tidal volume, and that is why at 24 the death may happen. And even in 18 or 12, where only 50, 100 or 150 ml reduction in the tidal volume is there, if patient has COPD, then that also can precipitate the acute respiratory syndrome. Why? Because COPD patient like tuberculosis, bronchiectasis, bronchial asthma, their 50% of lung is already diseased. Am I right? Tuberculosis is there, bronchiectasis is there, and they were anyhow compensating with the remaining respiratory reserve. And now, if we will decrease further tidal volume because of pressure over the diaphragm. Why tidal volume decreases? Because of pressure over the diaphragm, because once the pressure over diaphragm, lung cannot fully expand, and that is why tidal decreases. So, already 50% of lung is damaged by COPD, and then little decrease in the tidal volume can create problem. So, that is why we should not perform. Any patient who has chronic obstructive pulmonary disease or tidal, you have decreased tidal volume, decreased cardiac output. Third problem of the CO2 is hypercarbia. Unfortunately, CO2 has one big problem, that it is 200 times more absorbable than oxygen and 20 times more absorbable than room air. Absorbable means it gets absorbed by the peritoneal membrane. Our peritoneal membrane is a semi-permeable membrane. That is why nephrologists are doing peritoneal dialysis, because it can exchange the fluid very fast, even urea and even sodium potassium. So, peritoneum is very good, that it is a permeable membrane. So, once we put the CO2 inside, a lot of CO2 get absorbed and then it creates hypercarbia. There will be hypercarbia, means CO2 concentration in the blood increases. As soon as hypercarbia happens, then there is cerebral, arteriolar dilatation. Cerebral arteriolar dilatation will happen. cerebral artery will start dilating. Why? Due to hypercarbia, CO2 crosses blood-brain barrier, and once CO2 enter inside the brain gets disturbed and it gives command to the artery that dilate, I want more oxygen. And due to cerebral arterial dilatation, there will be cerebral edema. Cerebral edema. And once the cerebral edema develops, then the brain give command to the heart that I am in trouble, create bradycardia, and heart rate decreases, that is called bradycardia. Means initially there was 70 per minute, now it is 60, and that 60 will create further hypercarbia, because initially there was 72 time the blood was passing through the lung. So, it was getting more time to get purified, more time to throw the CO2 out and take oxygen in, but now it is 60. And then it will create further accumulation of CO2, further hypercarbia, further cerebral arterial, further cerebral edema, further bradycardia, and ultimately death can happen. And if death happen, and if any inspection happen, then they will ask you that do you have capnograph? And capnograph is essential, and not having capnograph is a medico legal issue. And capnograph is measuring our EtCO2, end tidal CO2 concentration. So, in laparoscopy operation theatre, capnograph is must. Without capnograph, if you do the laparoscopic surgery and if anything goes wrong, you may be get the medical negligence and penalty will be there. So, if you do the open surgery, you need 5 parameter monitor. In open surgery, first parameter is NIBP, that is non-invasive blood pressure monitoring. Second, you need ECG. Third, you need plethysmograph. Plethysmograph means graph of the pulse. This is plethysmograph. Fourth is SpO2, means pulse oximetry. SpO2 means pulse oximetry. And fifth is you need that this respiratory rate. Respiratory, this is, and if you are a laparoscopic surgeon, then you need 6 EtCO2, that is end tidal CO2 concentration, and 7th temperature to see hypothermia. These are the 7 parameters. And you know, if you will buy from BPL, that is a popular company, and 5 parameter monitor, it will cost you only 50,000 rupees. But as soon as you go to 7 parameter, they will ask you 1,50,000 rupees, 1 lakh extra for just adding EtCO2. Although it is a very small machine, just it is attached with the endotracheal tube and attached to the monitor, but they charge you more because they know that you are laparoscopic surgeon. So, 7 parameter monitor is required. So, CO2, now normally also we excrete CO2. Right now we are sitting, and if someone will end tidal means at the end of expiration measure how much CO2 is in our breath, then it will be 20 or less than 20. If you will start running fast, suppose someone is coming with a pistol to kill you and you run fast, fright and fight stimulation is there, then your EtCO2 become 50, 55, and you will feel the warm inside your head, and you see pulsation, you feel pulsation inside your brain. But at that time our body has adrenaline secretion. So, that adrenaline is not allowing the bradycardia to happen, rather it creates tachycardia and tachypnea. So, that is why if you are in fight or fright mode, you have breathlessness and your pulse is 120, 140. Am I right? Marathon race or something, a sports, or very vigorously you are playing or gymming, you have a tachycardia and tachypnea, because our body secretes adrenaline, but anesthetized patient, they do not have adrenaline stimulation. So, they get bradycardia rather than tachycardia, and this viscous circle, and then patient will die. So, that is why it is mandatory that EtCO2 should be there, but normal patient EtCO2 can be tolerated. Any tidal CO2 concentration, if it is high, he can tolerate, but if 50% of lung is already diseased, immediately it go to 50. And remember, if EtCO2 is 20 to 30, your anesthetist will be happy. If it go more than 30, he will increase the rate of respiration. What he will do in the ventilator? It was 12 per minute, he will make it 18 per minute. So, patient is intubated, rate of ventilation increases, CO2 started washing out. If still it is going, it is become 40, then he will tell you that, sir, decrease the intra-abdominal pressure. He will object to you that please decrease the intra-abdominal pressure. You were working at 15, he will tell you to decrease to 12. If you were working on 12, he will tell you that, sir, EtCO2 is increasing, decrease to 10. And if it is 10, he will get 8. Less than 8, unfortunately, we cannot work, because there will be no space in the abdominal cavity. If that also is not working, it is going 50, then he will increase the rate of respiration to double. Double means now it was 12, it is 24 per minute. But remember, unfortunately, increasing more than 24 will harm, because maximum rate of ventilation can be increased to 24. Suppose he will make 30 or 40, it will not work, because it will be so fast that there is no exchange of the gas. It will be without any benefit. Rather, it may decrease the CO2, oxygen, and there will be a problem. If it is more than half an hour, 30 minutes, up to 30 minutes, if it is considered more than 50, then there is a chance that patient will go to unconscious. Post-operatively, patient, you might have seen sometime that anesthetist wants to reverse the patient from out of anesthesia, and patient is not opening the eye. That happens due to increased EtCO2, and then another problem happens. Less trained anesthetists, what they do, that if the EtCO2 is going 40, 50 and tidal volume they say less, tidal volume was 500, now it is only 300, then they increase the pressure to compensate the tidal volume, because nowadays they do not do by hand, by ambu bag. So, ventilator is doing, so increase the pressure, and if increased pressure is there, ventilator is trying to inflate the lung, and diaphragm is trying to not let the lung inflated. So, what happened? Terminal alveoli will start rupturing, terminal alveoli of the lung rupture, and due to that pulmonary edema develops, that will create pulmonary edema, and due to this pulmonary edema there may be death, and it can lead to death. You might have seen some of the patient post-operatively, anesthetist is doing a lot of suction and froth is coming from the mouth, jhaag aata hai muh se, froth. That means that anesthetist is not changed, not good, and he has ruptured the pulmonary, ruptured the terminal alveoli, and that is why pulmonary edema has developed. So, good anesthetists, they never increase the tidal volume in the ventilator. What they increase is rate of ventilation. If tidal volume is 300, they will ask you to decrease the pressure, so that automatically tidal volume should increase. They will not increase the ventilator pressure. If ventilator pressure is increased, diaphragm is not allowing to expand and ventilator is saying that you have to expand, and then terminal alveoli put rupture, multiple terminal alveoli will puncture and then edema develops. So, that is why never increase the rate of this pressure of ventilator, increase rate of ventilation. And if you have a EtCO2, you are safe, because if in spite of increasing the rate of ventilation and in spite of decreasing your pressure, if still the EtCO2 is high, he will tell you to convert to open, because this patient cannot tolerate. Is it okay? That is why medico-legally it is important, and every 15 minutes anesthetist has to write on the anesthesia sheet that what was the pressure, EtCO2. He has to write, medico-legally it is important, otherwise he will be punished. So, this is necessary to keep in mind. Now, if the patient is already COPD and cardiac disease, EtCO2 can be big problem. Another important thing you should take care, that you should not give ondansetron in the laparoscopy during the anesthesia. Sometime ondansetron induced bradycardia happens. You can see ondansetron is one of the most commonly used antiemetic, and it creates severe bradycardia and hypotension. There are hundreds bradycardia after intravenous ondansetron and asystole, rare adverse effect of hypotension bradycardia. A lot of studies performed. So, what happened if intraoperatively you will give ondansetron, and if bradycardia happens, you will confuse that may be due to my surgery and due to CO2 not tolerated by patient, and you will confuse and unnecessarily you will open the abdomen. So, that is why ondansetron intraoperative anesthetists, good anesthetists they do not give, and if they do not know, you should tell ondansetron mat dena during laparoscopy, because that bradycardia will be confused with the hypercarbia induced bradycardia. So, that a small precaution should be taken. So, question is that if CO2 is that much bad, then is there any alternative? There are many alternatives. One of the alternative is helium. Helium create less bradycardia, less cerebral edema compared to CO2, 50% less, very safe, very good. But problem is expensive. It is very expensive. 1 kg of CO2, although I am exactly not up to date with the current cost, but I have been told that 1 kg CO2 is costing only 150 rupees. CO2 come in the cylinder in a liquid form. It is compressed CO2, so it becomes liquid, just like LPG. It is liquid form, and then it is coming in the gas form in the insufflator. That is why it is cold. Once it converts into gas, it becomes cold. That is why warmer is required. So, and 1 kg helium is 5,000 rupees. So, suppose in one surgery 5 kg CO2 is used, then it will be hardly 750 rupees or something, but here it will be 25,000. So, only few hospitals of the world they use helium for pneumoperitoneum, like some of the Cleveland or Mayo Clinic they use helium. We cannot afford it. Second gas which is substitute of CO2 is nitrous oxide, N2O. Remember, not nitric oxide. Nitric oxide is poison. In your exam there is one question that which is good. So, many of you take nitric oxide. So, because of not reading it carefully. So, nitric oxide and nitrous oxide sound same, but it is very different. So, nitrous oxide is used for what? Anesthesia. We are using nitrous anesthesia, nitrous oxide. So, nitrous oxide you can create pneumoperitoneum, that is very good. It has many advantages. One of the advantages is that it is analgesic. So, it never creates shoulder tip pain. No patient gets shoulder tip pain. Another advantage of nitrous oxide is that your amount of the nitrous oxide in the Boyle's apparatus will require only 50%. Normally 40% is nitrous, 60% is oxygen, but now in the ventilator you have to give only 20%. But one of the biggest drawback is it is explosive. So, you are not allowed to use any current, because if any fire, cost is not much, I think 500 kg, 500 rupees per kg. So, it is not expensive very much, but explosive, combustible means it itself get fire. So, you are not allowed to use cautery. If you use any spark, boom, it will. Air is not combustible, air helps in combustion, but air itself does not get fire. You put a candle, then candle will burn, but not this room. But if you put nitrous oxide, room will burn, like petrol. Nitrous oxide is explosive. So, any current, if you are diagnostic, it is very good. Tubal patency test, diagnostic, laparoscopy you can do, and it is used a lot by gynecologists for diagnostic laparoscopy. So, explosive. Third gas which is used is air, that is room air. Room air has little increased risk of air embolism, because even if 200 ml it will enter into the vein, it can create air embolism, but unfortunately it is used in laparoscopy. Most of the rural areas in India, they are using air insufflator, and companies are making air insufflator, because we do not have a strict government control on the instrument. Government has control on the drugs, but here drug act does not follow on the electronic instrument. FDA is taking care of electronic instrument also. So, there are many company which is air insufflator leke aao to they are making air insufflator, and I will show you how it looks like. Air laparoscopic insufflator, it is there in the air insufflator. These all are available in the India Mart. ये आपको 10-15 हज़ार में मिल जाएगा. These are air insufflator. This is CO2 insufflator, this is air insufflator, and some of them has CO2 and air both. So, these insufflators are available in the market. Inside there is nothing, there is just like a pump of the this aquarium, aquarium pump, and they have some regulators, and here also it will fix. If you will fix to 12, it will give only 12, and once 12 will reach, it stops, and it works. Generally air embolism does not happen, that is why people are using. So, you can use, but not tell my name, otherwise you can use. People are using, it is safe, but potential risk of air embolism. So, if something goes wrong, you will be in trouble. Ideally, it should be avoided. Fourth gas is xenon plus argon, or not plus minus, or better is to or argon. These are the two. This is also used, but these are ionizable. They are also inert gas, they also create less severe edema, but they are ionizable. Ionizable means it is only there are these two gases, xenon and argon, these are conductor of electricity. So, if you use the cautery, it will take the electron from one place and it will pass to the other place. So, if you are using it, you are allowed to use harmonic scalpel. because harmonic is not electron, it is a friction. Bipolar, monopolar cannot be used. So, there are many study done where xenon, neodymium was compared with the CO2. So, see, xenon is also one of the good gas which you can use, but improving the safety xenon, but xenon anesthesia in laparoscopic cholecystectomy is good approach, but you are allowed to use only the harmonic. You cannot use this monopolar because it is ionizable. So, ultimately if you will see, and it is also expensive, it is not normally available. Ultimately see that only the best is the CO2 only. You know why? What are the advantage of CO2? Advantage of the CO2 is, first advantage, highly absorbable. So, very less chance of air embolism. Second is cheaper. Third is easily available, Fourth is antiseptic. Why antiseptic? Because once it mixes with the peritoneal fluid, it is carbonic acid. And the fifth is anti-combustion. Am I right? It is fire extinguisher. So, it is anti-combustion. It will not allow any fire to happen. And ultimately, this is the best. But only drawback, you have to be careful that patient should be not COPD or cardiac disease, and another that you should be monitoring by end-tidal CO2 concentration. So, this is the fourth problem. Fourth problem is hypercarbia. Normal person can tolerate hypercarbia, but patient who is COPD and cardiac disease cannot tolerate hypercarbia. That is why in COPD and cardiac disease, gasless laparoscopic surgery is preferred. In gasless laparoscopic surgery, there will be no any pressure over the vena cava, no pressure over diaphragm, no chances of hypercarbia, no decrease in tidal volume, and no chances of air embolism. So, gasless has these advantages. Now, fourth problem is air embolism. With the CO2 also air embolism can form, because if it is up to 2 liter per minute, air embolism will not happen. But if CO2 goes more than 2 liter per minute, even CO2 can create air embolism. So, let us see the pathophysiology of air embolism. Here is the heart, this is the right atrium, this is right ventricle, this is left atrium, this is left ventricle, here we have the arc of aorta, and this is the pulmonary artery, and this pulmonary artery is going into the, this is lung. This is one lung and this is another pulmonary artery going to the another lung. Now, here we have vena cava. This is vena cava, inferior vena cava, and you know you are putting varus needle, and varus needle has entered into vein. Remember, hypercarbia never create air embolism, because hypercarbia is due to generalized absorption of the CO2 from entire peritoneal membrane. So, they cannot unite to make a bubble. In hypercarbia, overall concentration of CO2 in the blood increases, in the plasma it increases, because CO2 absorbable, so directly it dissolves in the plasma, but it will never make a bubble. Bubble is formed by two means. One is directly your varus needle has entered into vein, or during extensive dissection you have the excessive pressure, like you are doing radical hysterectomy or liver resection or severe myomectomy, and a lot of pressure is there and one of the venule is open. And now CO2 will directly enter into that vein just like IV fluid, IV infusion of CO2. So, this is a bubble and here is a bubble, and this bubble will enter into the, this is bubble is entering into the right atrium and then going to right ventricle, and from the right ventricle it will enter into the lung and it will create pulmonary air embolism, and then right heart failure followed by left heart failure. If you will use this air embolism, this problem is a lot. I am showing you, here is the air insufflator in my hand and it is turned on. ऐसे पकड़ो, power दे दियो उसमें, but light is, yes, it is powered on, and you can see here there is, it is written CO2 and air. So, if I put and see, it is writing what? Air. now इसको ऊपर दिखाओ, ऐसे दिख नहीं रहा है, it's not visible. Can you see it is writing air here? AIR, air, am I right? This is air, and they have a warmer also. This is warmer. You can increase or decrease the pressure, and here I am starting the flow. Start, and see it will start giving pulsatile, and it is on the gas. See, and I am attaching these gloves, and they also give you pulsatile flow. Pulsatile flow. And see, this gloves is distending. No CO2 cylinder is attached, air insufflator. And as soon as this 12 will reach, flow will stop. They are good, but medico-legally not good, because it is right now, it is why it is flowing, because little leak is always there here. I cannot make it completely airtight, but if I will make it complete airtight, it will stop its own. So, this is air insufflator and you can use. So, but it is risky. So, what this create? Air embolism. Now, there are many questions which comes in the exam due to air embolism. One of the most important question of air embolism, that anesthetist is working with you and suddenly anesthetist is disturbed, suddenly anesthetist is afraid, he is little bit disturbed, standing, and he is in hurry to asking adrenaline, asking something, and he is confused what to do. Now, what is the possibility? Air embolism or DVT, thromboembolism? How you will differentiate it is air embolism, not DVT? Pardon? Yes. One is that why it will increase or decrease? Carbon dioxide going, very good. One of the biggest difference in the air embolism is there will be sudden collapse. In DVT, sudden collapse will not happen. In air embolism, within few minutes your patient will die if you will not do corrective measure. DVT take hours to die or maybe days to die. Why? Let us see the difference. What happens in air embolism? That this air bubble comes at the level of this valve. This valve is which valve? Pulmonary valve here. This pulmonary valve. As soon as air comes in this pulmonary valve, then immediately what happens? That valve will collapse all the blood down. No blood can enter into the pulmonary artery. Why? Because this valve is made for protecting blood to go back, it is not made for protecting air to go back. Let us make it more simple. Have you seen the water pump in your village? You have water pump. If this water pump takes air, what will happen? Entire water column drops. After that you keep on pumping, will it come? It will not come. You keep on pumping, water will not come, because now air has taken, and this air you will keep on pumping, it will not suck the water, because this valve is made for stopping water to go back, not for air to go back. Or your car or your generator, diesel generator has taken the air. Now merely adding the diesel, it will not start, you have to call the technician. He will open and he will remove the air. Nowadays expensive car, they have a pump, so it itself will suck the petrol. But old car, old Ambassador or Fiat, when your petrol is empty and it has taken air, just adding the petrol will not start your car. You have to call the technician, and they were opening the tube from carburetor and pulling it, throwing the air out and then connecting it, and then it will get a start, because once the carburetor has taken the air, it cannot suck the petrol. Same way your air pump, if it has taken the air, it cannot suck the water. So there will be complete collapse. Pulseless patient, within seconds patient become pulseless. In DVT, patient will not get immediately pulseless. Why? Because in DVT one clot is coming, and once a clot comes, like suppose this is a clot, and clot comes, then clot cannot block both the lungs simultaneously. Clot cannot clot all the lobes of the lung simultaneously. It can only block one lobe, but remaining other lobes are working. So what happened? Pulmonary hypertension increases, and then gradually right heart failure and then left heart failure will happen. Am I right? But here no blood is pumping in the pulmonary artery. So absolutely immediately pulseless. Another you take, and why it is CO2 decreases? Because no blood is going into the lung now. So dead person ETCO will increase or decrease? It will decrease, because there is no blood going into the lung, so no CO2 is going into the lung. So you will see it was 40, now it is 2, 3, 4 or 0. Because completely patient is pulseless, BP stopped, pulse 0, anesthetist is jumping, trying to do CPR, he is confused and asking for defibrillator and these things. So what you do? Immediately you take a stethoscope and put in the pulmonary auscultatory area. This pulmonary auscultatory area is second right intercostal. And once you put the stethoscope, you will hear a peculiar murmur that is called meal wheel murmur. Meal is M-E-E-L. Yes, not meal. Meal wheel murmur. Or in some book, they describe water wheel murmur. This is water wheel murmur. What is this murmur? This murmur is the same sound which you might have listened in your bathroom once your water supply is going to be over. You are taking a shower and your water tank, who is in the top of the roof, that is getting empty. Then you might have heard a peculiar sound come, sound. Have you listened it? Why this sound is coming? Little air followed by some water. Again little air followed by some water. So it gives you sound. So it is sound just like a wheel running on the water. Sound, that type of murmur you will listen. And then you can save your patient life. How to save? Just turn the patient completely left and fully head down. Turn the patient completely left and fully head down. Pulse will come. Why? Because as soon as patient is left, then air has a tendency to go up. So, from the right ventricle, bubble will remain in the right atrium, it will not pass to the right ventricle. Am I right? And a air bubble which was touching the valve now go to apex of ventricle and blood will touch the valve. If you have a water bottle and keep the water bottle like that, air go up. Water. Have you seen your old scooter in the village? If it does not start, they tilt it to one side. Why they tilt it to one side? Because air from carburetor will go out and petrol will enter. So, they tilt the scooter and then they kick, and then a scooter starts. So, same way you turn the patient to the left and head down, then blood will come at the level of valve, air will go away, and air which was entering into the heart will remain in the vena cava, because air always remain up, and then pump will start, pulse will come back. So, in air embolism you must differentiate from the DVT. How? First, in DVT sudden collapse does not happen. Second, EtCO2 increases in DVT, it decreases in air embolism. And the third, you have a water wheel murmur or meal wheel murmur. And fourth, turning the patient to the left and head down will prevent air entering into the lung. DVT it will not prevent, because it is kachra, it is a clot. So, if you put head down, it will go more, because it will go more towards the gravity, air go against the gravity, but a clot will go more towards the gravity. So, to turn left, turn down, no problem, nothing happens. Air, you can save the life of the patient, immediately turn the patient fully, and now blood will come, because air bubble will remain in the vena cava, and then fresh blood will come and it will remove all the clots. And if your anesthetist is very good, then he will use a catheter, that is called Swan gauze catheter. This is Swan gauze catheter. This catheter is available and it is called pulmonary artery catheter. So, in this he will put it into the atrium and a frothy blood will come out in the jugular vein. On the right side he will put in the atrium and a frothy blood will come out and patient life can be saved. So, this is the problem of the air embolism. So, due to that reason, these four factors, major factor, laparoscopy should be avoided in the patient who has a cardiac disease and pulmonary disease. But remember, this word severe is important. If you see in the previous slide, it is severe COPD and cardiac disease, not the mild. Mild is okay, and that is decreased venous return, decreased cardiac output, decreased tidal volume, decreased minute volume, hypercarbia and air embolism.